All right. Hi, everybody. I know we're supposed to have this in person, but, Dr. Helova had a conflict, so we're doing it in Zoom. So some of you are there in the room. I'm sure you can hear me. The others can hear me in Zoom, I guess. All right. Today we have Dr. Anna Helova. She's an assistant professor in the Department of Health Policy and Organization at our School of Public Health here at UAB. She's the deputy director of the Sparkman Center for Global Health. Dr. Helova serves as the chair of the Global Health Operations Committee of the Consortium of Universities for Global Health, CUGH. She has over 22 years of experience working in academia and global health in the United States, Europe, Africa, Asia, and Central and Latin America. Her research interest is in maternal and child health, behavioral science, mental health, access to care, HIV and AIDS, intersectional stigma, social determinants of health, both domestically and internationally. And today she'll be talking about her experience and work in LMIC settings. So with that, please join me in welcoming, our friend, my friend, and a global health scholar, a rising star, Dr. Helova. Anna?
Yes, thank you so much for that very generous introduction, Sarip, Dr. Shrestha. Thank you so much for inviting me to speak to you today. Let me see. My camera is being a little bit stubborn. Okay, it's working now. Okay, thank you so much. Thank you so much for inviting me. Thank you so much for joining us today, either in person or on Zoom. And I hope that you will enjoy this presentation. The title is rather long, but a fairly simple concept, resilience and global health practice, strengthening health systems and communities in resource-limited settings. And I'm going to say that right from the beginning. When we say resource-limited settings, I don't mean just international locations, Africa, Southeast Asia, which is something that we usually think of, but I mean even rural Alabama and and a lot of the domestic locations. So just so you know, right from the beginning, resource limited settings it's not just meant low and middle income countries, but it's really the domestic settings as well. Okay. Okay. Goals of these lectures, simply put, is define and contextualize resilience and global health practice, examine determinants of health system resilience and community resilience, present one of preliminary data from one of our case studies, show you some future directions of where we are heading, and then I will open up this session to any questions that you might have. So let's just again start with some simple definitions. So we know that we are of the same mindset as we are approaching this lecture. So what is global health practice? Global health practice is application of knowledge, skills, and strategies to improve health and achieve equity in health for all people worldwide, again, including Alabama or any other domestic setting, particularly across national, cultural, and socioeconomic boundaries. It involves implementing evidence-based interventions, policies, and systems, strengthening approaches that address shared global health challenges. And the shared global health challenges can include a number of things. For example, disease-wise, it can be the communicable diseases, non-communicable diseases, or even, as we are talking today, the resilience of health systems. Now, let's try to define a little bit community resilience in health systems. I do have to acknowledge that we don't really understand these concepts fully, and especially as we try to translate these concepts into the low resource settings. But these are the definitions that people came up with and are probably the most recognized as the definitions in our field right now. So what is community resilience in the health systems? It's a process linking a set of network adaptive capacities capacities at individual or community level to a positive trajectory of functioning and adaptation of the health systems at the community level after health shock. Let me actually pull down because a level after a health shock. Community resilience operationalizes health system resilience at the local level. So what it means is basically transforming communities, empowering communities from becoming passive recipients to active partners in sustaining health, equity, and well-being of their community amid adversity. So hopefully this is clear now that we are really focusing on communities, empower them, and it's using that pathway to a stronger health system and communities. Some of the domains, and again, based on the sources, these domains can actually look a little bit different. But this is the source and most recognized, again, definition as used in the context of low resource setting. So those domains are leadership and governments, health, local knowledge, community networks and relationships, communication, and resources. Today, I'm going to focus a little bit more on health, specifically health workforce. But I will, as you see, as I present, you will see a little bit of the cross relationships and cross in between all of those domains that I mentioned. And of course, all of these domains are very important, right? As we know, in public health, you cannot really achieve health and good health outcomes, resilience in the community and health systems, unless you have all of those, address all of those domains. Okay, so now the case study. We call this study REACH study, Resilience Amid Challenges in Healthcare. And I will be talking about the impacts of societal disruptions on mental health and quality of life of health workers in Kenya. So a little bit of background of how this study came about, because this is an example of how it really is in the practice, right? We are somewhat all tired of talking about COVID, but it actually started with COVID. So I'm going to acknowledge that. We were conducting our study, COVID came, and we were unable to really see our pregnant and postpartum women participating in one of our studies. We had to came up with all kinds of strategies to really restart the study, adjust the procedures, and finalize the study. So this REACH study came to really just take a look at our health workers and see how they are impacted and what can be done to really for them to really be able to perform their functions and thus both still provide the services to our pregnant and postpartum women and the communities, and so basically provide those services and keep the services going and the health system going. As we continued with this study, we started with with the survey among the health workers. But as we continued, so we realized really COVID is really just a proxy for a lot of different sources of the health service provisions, right? It can be anything from the climate events, flooding, so mudslides, all of these events, rain. It can be anything from geopolitical events, protests, strikes, even results of elections, any kind of reason like this. And then as we started talking to the clinic providers, to the administration, we heard more and more just about a daily life, how much stress and how much need there is for the mental health interventions among health workers, but professionally and personally. And so this study had started with just let's take a look quickly how COVID is impacting our health workers, and going all the way to now we are creating the interventions, trying to look at the work environment and see what can be done. So a little bit of the brief background for those of you who are not familiar with this setting. Kenya is located in East Africa. It's a priority country for fast track 95, 95, 95 targets. Those are 95% being tested, 95% uh, being connected to care, and 95% then achieving so viral suppression. So basically maintaining a pretty healthy life, right? Considering that they have HIV. So often we also talk about the last 95, which is a domain of quality of life, but it's not officially still not formally included within the trackers. So Kenya is the priority country. The current Kenyan adult treatment cascades now stands at 90, 82, 92, which you can see are far from the 95, 95, 95 targets. So they are below the UN targets. COVID-19 further slowed HIV gains, and we are yet to see other geopolitical recent changes how they will be impacting this further. Alongside morbidity and mortality that we've seen the indirect consequences of COVID-19, strained HIV services, and even prenatal services and postpartum services, and then maternal and child health services were also strained. Other than our patients, there was also a huge impact on health workers, and there were heightened community level stressors to add to all of that. Health facilities and health workers, including lay health workers, are often sources of support for community members during the times of crisis. Now, as I define the other terms, I also want to talk about what are the health workers and lay health workers in this context. Health workers are usually considered the clinical staff, doctors, nurses, pharmacists, and other highly educated clinical staff. Lay health workers are often, in this context, community health workers, peer educators, mentor mothers. It's a cadre that is pretty common in this setting, not so common, for example, in the United States. These are the women that have a shared experience. They usually live with HIV. They have been through the experience of being pregnant and postpartum, have a child while also living with HIV. And other health workers of the similar cadre. So, what were the general objective of the project? As I mentioned, it started very narrow, just looking at the impacts of COVID-19 pandemic on health workers and health system utilization, but then we expanded all the way to other disruptions in communities on health workers, and we started looking at how we can develop the intervention, what can be done, what kind of approaches, strategies can be applied to build the resilience and coping skills among health workers. So our study was nicely aligned with the Kenyan and global HIV-related health priorities because we seen this as a pathway to improving the mother to child transmission, so lowering the mother to child transmission of HIV. We seen this as a path to improvement of mental health among workforce, especially in the context of workforce shortages. And we've seen this as an engagement of lay and community health workers and engagement of populations affected by HIV. And also it's a way of promotion of health-seeking behaviors and outcomes through primary care. Just very quickly to the methodology and study setting. So southwestern rural Kenya is a priority area for HIV research and services. Adult prevalence is about, so the country is the priority area, but also in the southwestern Kenya, in Kisumu, Migori County, where we work, the adult prevalence is more than 3 times of the national prevalence, and it's almost around 5%. That's the national prevalence. That's the county, the Kisumu County and Migori County. It's all the way up to the 20% across counties, and we see about over 6,000 pregnant women living with HIV annually. We work with the Kenya Medical Research Institute, which is basically the Kenyan NIH. And so we work with the Ministry of Health public facilities that provide these integrated HIV and antenatal postnatal care for women living with HIV. Again, very simple. I don't want to overwhelm you with the methodology, um, uh, but we are using the ADAPT ITT implementation framework, very commonly used for the adaptations of interventions or development and adaptation of interventions in the context of HIV. Our aim one was assess the impact of and resilience to COVID-19 among HIV healthcare workers, and so we conducted the COVID-19 survey among 200 health workers in the period of 2021 and 22. We also conducted 4 focus groups, 2 with clinical personnel and 2 with lay health workers across 2 different counties in Kenya, Kisumu and Migori counties. At 2 different clinics, and we conducted 10 key informant interviews with stakeholders. So this was a sample size of 40, and we just finished up the resilience survey that extended some of our outcomes and the scales that were included within this questionnaire. So we are actually undergoing analysis of the survey, and we are getting some really nice results, but they are not ready yet for this presentation. So stay tuned. In aim 2, we didn't want to integrate the findings from these mixed methods and adapt existing trained models and job aids for focus on health worker resilience and preparedness. We conducted desktop literature review. Again, the publication on this is about to be published. So hopefully they will have a nice impact. It provides a nice little review of potential interventions. And we also synthesize the findings from A1. In aim 3, we conducted participatory workshop, which where a lot of the administration, policymakers, and other stakeholders provided an input into what we developed. So we are now in the process of developing the intervention, train staff, and conduct a very little. It says beta testing is more like the testing of the concept rather than what we understand under the beta testing, to just see the adaptation efficacy among 20 health workers. Okay, so again, the results that I'm going to present are mostly from the 4 focus groups and 10 key informant interviews, which included the health workers from the integrated HIV antenatal clinic with at least 3 years of experience. These were conducted in English. Most health workers in Kenya in this area are really educated in English and proficient in English. When we conduct the studies with other populations, we of course translate our tools and conduct the research in the local languages, Luo and Kiswahili, but this was conducted solely in English. We conducted conducted the rapid thematic analysis using the DUCE software, and of course we obtain ethical approvals from the University of from UAB and then from the entity in Kenya. Just very simple socio-demographics characteristics. So we had 30 women, 9 men, which nicely presents the distribution among between the lay and clinical health workers in Kenya. Age, median age or mean age, I think it's mean age was 39.4. So about 87% had college education, 30 were married, all of them identify as Christians. Again, very representative of the population in this setting. They had 2.9 children, and feels about 54% identify as clinical health workers, 16 as lay health workers, two working with the government or like the policymakers. They had 9.6 years of experience in the current job and 12.4 years of experience in the profession. And our total sample was 39 people. Okay, so just going to spend a little bit of time on this integrated model. So within this model, we combine several elements. So we combine the resilience and quality of life in HIV healthcare workers, and we also included some of the pre-implementation outcomes. So this shows you a little bit of the theoretical frame, so model that we are following, looking at the stressors or risk involved. What kind of adverse impact, including the poor health outcomes, these stressors had, looking at some possible resilience pathways, then looking at elements of proposed intervention, including the implementation, delivery, components, and approaches, and then looking at some expected outcomes. So this is from one of our papers. Hopefully you can see that clearly. I'm not going into too many details, but as I mentioned, while we started this study really as the COVID-19 pandemic started, it really this study really expanded to a lot more. And so now we are looking, yes, the COVID-19 was basically the starting point and a proxy of what happens when the health system experiences a major shock. But it's also professional life, stressors in personal life, and other events that cause service disruption, including like the climate-related event or geopolitical events. The adverse impacts that we've seen, including the poor health outcomes, using quality of life framework as a framework to guide us on the physical end. We've seen a lot of the fatigue, sleep deprivation, and adverse health outcomes in health workers. On psychological domain, we've seen a lot of stress, depression, burnout, frustration, and also reduced motivation to conduct their work, and also fear and other psychological impact. On the social domain, we've seen a lot of stigma, isolation from family, community, interrupted or disturbed relationships. On environmental, on the personal, we've seen a lot of the limited financial resources. Lower access to food, for example, was a big one, especially among the late health workers that are a little bit more susceptible to economic impact. Uh, Whereas in the work environment, we've seen lack of adequate resources, decrease in service utilization, adversely affected quality of patient care, increased work demands, and also a lot of issues that are related to remote work, especially in this setting. Some of the resilience pathways that we've seen, again, utilizing the quality of life framework on the physical end, rest, lack of rest, and self-care, on the resilience pathway, actually utilizing those techniques that will improve the rest and self-care could be a possible pathway to resilience among health workers. On psychological and stress management, development of coping skills. On social domain, creating good work environment, increasing the peer and family support, and also utilizing religion or spirituality so it's a big thing in this setting. On environmental and leadership policies, sufficient resources, intervention programs to build resilience embedded within the clinic and health system. Okay, checking the time, making sure that I'm staying on top of. Okay, good. All right. So let's continue. So what have you seen from the main elements of results? So we've seen significant mental health challenges that happen during societal disruptions and even in daily life. The mental health challenges included a lot of trouble concentrating, restlessness, feelings of inadequacy, and disruption also strain personal relationships, impacting couple dynamics and family interactions, often exacerbated by financial stress and difficulty accessing basic supplies. And just very quickly, one of our quotes from this research, just to hear that in the voice of our participants. Health workers undergo a lot. We go through a lot during our day-to-day activities, which really affects us mentally. So I feel if maybe that mental support can be provided to help their workers, then it can be of great help to us. Some of us nowadays, health workers, are like policemen. I'm sorry to say that you go through a lot. You end up maybe dying out of depression or even committing suicide through what maybe you see at the facility or what you encounter during your day-to-day life. So mental health support is very important for health care workers. And again, even though this is rural Kenya, we know from experience and from our other research, this very much resonates in other parts of the world and including rural Alabama, especially if you think of that context of COVID-19 pandemic and what followed. So mental health impacts, as I mentioned, we've seen a lot of depression, anxiety, stress, frustration, burnout, decreased motivation, and which impacted the ability to cope with daily personal and professional demands. I'm not going to read every quote just to move the presentation forward. But basically, as they are saying here, it was really stressful. It was not easy. We were not ready for it. We did not know where to start from. So others interesting results that we had. So again, the key informants and even participants expressed the pressing need for programs focusing on the mental health, and many mentioned that they lack formal training in any kind of resilience and stress management. And explained that there is stigma and mistrust related to accessing mental health services for their patients and also for themselves. But they expressed that a lot of our participants expressed that there is a willingness to participate in this kind of training, provided that is adapted and implemented in a way that would be helpful to health workers and accessible to health workers. And so this is suggesting potential accessibility, acceptability, and feasibility in this setting. Preferred components, so health workers and key informant recommended focusing on coping mechanisms, stress management, and emergency preparedness. Some of the suggested techniques included mindfulness, cognitive restructuring, relaxation, talk therapy, positive thinking, teaching protocols for handling emergency situation, as well as mental illness stigma reduction strategies. And of course, later on, they also talk about the target audience and emphasize really not to forget about the lay health workers and not to focus this only on clinical health workers. Preferred delivery methods was still one-on-one sessions. A lot of them were still concerned about stigma related to mental health, especially talk, for example, about that a lay health, so that a health workers is often seen as that pillar, strong pillar in the community and health systems, and so they were concerned if their patients might see that they're undergoing some issues that might affect provision of their care. They also talk about the in-person or video calls, because it was viewed as more personal and beneficial, being able to pick on nonverbal cues, and preferred location, they said a clinic or work site due to the financial and time constraints. Again, participants also call for safer and better work environment, protection of their rights, and they seen that as a path to create a positive work environment, which might lead to the improved ability to conduct quality of work and patient care, and also then lead to the increased job satisfaction and improved motivation. So I'm going to read this quote just again to hear the voice of our participants. I would say that one of them is making the health facilities friendly for health workers. Because if you look at where we work, like when I came in the morning, it was so much stress because the environment, even that alone really tests you. You see, if the environment is not conducive, the environment alone can irritate you. Remember, the work also has challenges. So if you combine the working environment plus the other standards of work together, it can make somebody choose not to learn to laugh when working. So I think one of the things ensuring the environments is conducive for work, providing the resources for the staffs. And this is just a summary, again, utilizing our framework. I'm just going not going into too many details here. Hopefully you will be able to read that in our upcoming publication. Going straight into conclusions for this particular sub-study, societal disruptions were described as having profound impact on health workers' mental health that ultimately affected both their work and their quality of life. Programs focusing on building resilience among health workers could have a positive effect in the event of future societal crisis, as well in the context of everyday professional burnout or stress, or even personal experiences. Providing a good environment was also seen as crucial to building strong health systems, and such programs are potentially feasible in this setting and align with the Kenyan and global health priorities. Key recommendations coming from this study: health programs should prioritize accessible mental health services intervention to enhance the well-being of health workers, to build that resilience, and for navigating ongoing challenges in their roles that support their ability to thrive and provide quality of care. Intervention could address challenges of societal crisis and everyday professional burnout. And findings highlight the importance of tailored, accessible mental health support for health workers in resource-limited settings. Okay, so as I mentioned at the beginning, when I talk about the domains of community resilience and health system resilience, our futures, today I talk about the study that was focusing really on that health domain and just touching slightly on the other domains that build the resilience or affect resilience. In our future studies, we want to again expand our focus more across all of the domains and see how we can build that resilience and what are the determinants of that resilience, community resilience in healthcare systems. So our future studies will actually look at this larger context. I do want to acknowledge our study participants, collaborating investigators, staff, and trainees from our partners, Kenya Medical Research Institute, UAB, University of Michigan, University of North Carolina, Chapel Hill, our funders and supporters, including Kenyan Ministry of Health, and then our funders, UAB Centers for AIDS Research, and National Institute of Mental Health. And again, all of what I presented does not represent the views of our funders or necessarily the University of Alabama at Birmingham. Uh, this is the picture of some of our study staff. Is not everybody. Our team is much larger, but these are some great people across Kenya, US, and some other countries. And again, future focus. So where do we want to take this research? Is really start looking at the health systems and communities in rural Alabama, in Kenya and Nepal, and other then potentially other resource limited settings in the world. These communities have a shared health challenge, which is including this, which is not limited to natural disasters, and are so these all of these communities are frequently affected by these public health system disruptions due to natural disasters, which then adversely affect health of the community. What is our assumption in these studies, or the premise is resilience in health systems and community resilience will lead to improved health outcomes. There is a lack of instrument or a way to measure the community resilience in health system in these resource poor settings. And so really our goal is to develop such tool and being able to measure this concept, which can then lead to strengthening and capacities and structures in response to health shocks. And product that we envision is the contextually appropriate tool to assess community resilience in health systems following natural disasters, and then not limited to just natural disasters, allowing translation of findings into a locally relevant community resilience resource development. And these are the partners that we are that's our collaborators. So within Alabama, we started collaborating with the Alabama Department of Public Health and West Central Alabama Community Health Improvement League. In Nepal, we are working with the Kathmandu University and Dulikal Hospital, and within Kenya, we are working with the Ministry of Health and then Siaya and Kisumu County uh, leadership and partners, including the Center for Health Solutions. Okay, in summary, to bring this lecture together, we discussed some of the examples and approaches in global health practice that may lead to strengthen health system and communities and their resilience. And within those domains, I focus mainly on health domain. But the community resilience with health systems, of course, across all of those domains, plays a vital role in crisis response and preparedness. In the operationalizes health system resilience at the local level, transform communities, empowers communities to be able to transform from passive recipients into active partners in sustaining health, equity, and well-being of their community amid adversity. And in the recent and rapidly changing geopolitical landscape, other domains such as governance, financing, resource allocation will play increasingly critical roles in shaping the resilience and sustainability of health systems. And again, even though I provided example focus on Kenya, this is a highly relevant concept to Alabama as well. And we are looking forward to implementing some of the lessons learned and some of the strategies learned abroad in a reciprocal way within the Alabama setting. This is my contact, and I'm happy to answer any questions that you might have. Thank you.
Thanks. Thanks, Anna. Well, if you have any questions, please put it in the chat box or, raise your hand. So while everybody's thinking, let me ask you one question. You mentioned in
Mhm.
the beginning and also, with your future focus, that it was going to be more on the resource limited settings and not just in LMICs. So my
Mhm.
question is, with the data, with the results that you had, were there any surprise findings that you may not have expected and maybe different? Maybe it would be different in resource limited settings, specifically in the context of rural Alabama, for example.
Um, so that research is just starting, so I cannot fully answer that. But maybe not shocking, but more so a realization with with just how similar really those concepts are and how shared that experience is across these settings, and realization that maybe there needs to be a higher level of exchange of solutions across these settings because that knowledge transfer could be really helpful to help facing the shared challenge. And we are seeing more and more this concept of reciprocal innovation, where we take something from LMIC settings and implementing it in Alabama. Another thing, I guess, that we kept realizing just how much this concept of resilience encompasses, and also just how much attention has to be paid, not just to the shock itself, but really just to day-to-day struggles as well. Um, because while the shocks, the health shocks, for example, the COVID-19, but not limited to that, right? It can be a hurricane, whatever is happening, right? That shock is highlighting the problems a little bit more, but it's really, so we do see the struggles in everyday life, right? Like for example, we just been to the Black Belt Institute in Wilcox County 2 weeks ago, and and the the problems accessing the healthcare is so high. The clinic is actually, the access might be even worse within that setting than it is in the rural Kenya, for example, or Nepal, right? So we do have to pay attention to the daily struggles, in addition to being prepared for that high level shock when it comes. Yeah, hopefully that answered your question.
Yes, it did. And I got frozen and got kicked out a little bit, so I missed. But I'll catch up with you.
So
So
well,
I
then
asked,
I trying to answer that question. Cool. Yes.
all right, thanks. Um, Anybody else has any questions for Anna?
Um, I wanted to know, were there any main challenges in the integrated resilience model, and were you able to address them during data collection or analysis?
Uh, Yes, there were multiple challenges. So again, this study kind of was developing over time. So we started this study really just to see the immediate impact of COVID-19 on our healthcare workforce in Kenya. But then we just kept expanding, right? And we started with just very straightforward impact. And then we realized that we have to go more into the concepts on scales of the jobs as satisfaction, for example, expand that understanding of the resilience and what we are actually measuring, what groups we need to involve in measuring this. And so we just kept adding basically the domains and elements. And now we see that just addressing the domain within the health workers, even if it includes some policies, is not sufficient. That we have to dig deeper and we have to go beyond the health systems and policy system, go actually to the community, and empower them and include the community. So there were a lot of as you see this process and our methodology, it has been really adapting to what's happening in the environment. As we learn, it was incorporated in the next collection instruments and methodology.
Great. Thank you.
All right. Any other questions? I don't see any hands or anything in the chat box. Well, if there are none, well, let's all join in thanking Dr. Helova for the great presentation and the insights. Just a note, next week's presentation is also virtual. We'll have Dr. Paula Strassel from University of Maryland. So with that, thank you, Anna, and wish you the best with your studies.
Thank you so much. Thank you so much for inviting me, and thank you so much for participants for attending the lecture. Thank you.